All right, good afternoon, everyone. We are led today by Nick Seabrook, the Executive Vice President at SimiTree, with over 25 years of experience in home health and home care consulting. Nick is a recognized industry leader in everything billing, compliance, revenue cycle, everything in our industry that you could possibly kind of do, and also a frequent national speaker. So we are very lucky to partner with both SimiTree and Nick today for this portion of the compliance program series. Just a quick note before we begin. Today's session will use the Q&A feature only. So if you have questions during the presentation, please submit them through the Q&A panel, which you'll see near the top of the screen. We'll address as many as we can during the end of the session, and hopefully we can get everyone's questions answered. So without further ado, I'll go ahead and pass it over to Nick for today's topic, Medicare payment overview and key issues for home health and hospice.
Great. Appreciate the intro, Dan. Thank you very much. Love the haircut. Again, thanks for the intro. I'm Nick Seabrook, one of the EVPs here at SimiTree, and today we're going to talk about Medicare payment. As Dan had mentioned before, all of my career has been spent in home health and hospice and in reimbursement and revenue cycle. So this is a topic that's near and dear to my heart. We've seen a lot of changes over the past 25 years. And we're going to start off here talking about the home health side. So home health went through a fairly recent change. We're in year 5 now of the new model, year 6, I should say. We're 5 years plus in to the patient-driven groupings model, so PDGM. And what we're going to dive into is really all of the components of PDGM and how the billing works. It's a little unique compared to some other aspects of healthcare billing for those of you who have experience there. So we're going to take a deeper dive into home health billing. We're then going to transition over to the hospice side of the equation. So we're going to look at some of the Medicare hospice billing, and then we really want to set the stage for the next series coming up in our exciting series that we're able to present here, co-branded with ourselves at SimiTree and also with CHAP, looking at some of the home health and hospice billing challenges that we typically encounter, and then what are those issues and how do they translate over to the compliance side of the house as well. And then we also want to make sure we save time for Q&A. So if you have questions throughout the session, please use the Q&A feature in the chat. If you look at the toolbar, you should see a Q&A feature to be able to ask any questions that you have that come up throughout the presentation. So we'll start, like I said, with the home health side of the business, and we're going to talk about the patient-driven groupings model, which again was introduced in 2020. First, we're going to talk about some of the home health requirements, and then again, this all is going to tie into the billing and how the billing component works in PDGM. So just some reminders from a home health standpoint. From a coverage standpoint, first and foremost, your patient needs to be homebound, right? That's a considerable and taxing effort in order to leave the home. That's the first requirement to receive these Medicare benefits from a home health standpoint. So homebound status is first and foremost. Number 2, being under the care of a physician or allowed practitioner. Number 3, receiving services under a plan of care, right? We need to have a plan of care in place for the care that's being provided to those patients. You can see also having a face-to-face encounter with a physician that needs to take place within specified time points for those patients as well, and then needing that skilled care on an intermittent basis. So PDGM, again, we're in year 6 here of PDGM, started in 2020, right before the pandemic. So year 1 of PDGM was quite an interesting time. And prior to PDGM, we had a system known as PPS, a prospective payment system. There are some similar qualities, but really what PDGM has really aimed to do is it's taken a lot of data, and CMS worked with a group called Apt Associates to do a big data analysis looking at patient care, patient costs, and what the reimbursement is. So really, at the core of what PDGM is trying to do is it's trying to align the reimbursement with the actual cost of the patients. And how it's doing that is it's looking at different clinical characteristics for those patients and it's trying to take into account, based on those services being provided, the volume of services being provided, and those costs that go with them. They're trying to align that with the costs. In the previous model under PPS, there was a couple of different factors that really tied into some of those higher reimbursing patients, namely therapy services. So under that PPS model, there was a big emphasis on therapy. They really wanted to shift away from that when they switched over to the PDGM model. So how does the payment structure work? Well, the payment structure is built into 30-day periods of care, right? So if you have, and when I say 30-day periods of care, that doesn't mean in a specific month you're going to be reimbursed for that month and that month only. It's going to be based on the 30 days starting whenever you start. So I know today is September 11th. So if you were having a period of care today, that care would start September 11th. And it would cover the rest of the month of September. So that would be 20 days in September, and then the first 10 days of October. So your first period of care for that time period would be 9/11 to 10/10. So again, prior to PDGM, there was an episode that covered 60 days. Now under the PDGM model, we have this 30-day period of care. And you can see there from that second bullet, there's patients' clinical characteristics, their functional status, other factors that are going to be determining what that payment's going to be. Which brings us to the third bullet there, is the case mix adjustment. So essentially, based on those patient characteristics, your patient's going to be categorized into one of 432 case mix adjustments. And based on those case mix groups, they all have different weights, and that weight is then applied to whatever the standardized Medicare rate is, and that determines what your payment is. Consolidated billing there, so you can see everything's kind of wrapped in. It's a episodic, more of a prospective payment type of bundling model. So it's not like you're getting reimbursed individually for the number of services being provided. This is all based on historical data and those patient characteristics. So all of the nursing, the therapy, the social work visits, the home health aide visits, those are all bundled into that same claim. It's a consolidated bill. Your supplies are also on that claim as well. There's no reimbursement for the supplies. It's all built into that rate that's established based on the case mix scores, based on the HIPS code or the HHRG, which will go into kind of how that architecture works here in these subsequent slides. So that leads me into this slide here, talking about Home Health Resource Group, or the HHRG. The HHRG is basically the structure for how Medicare knows how to pay you, right? So this is, if you see here, there's 4 different subcategories to the right. Those are all color coded. We'll start at the top. We have that admission source and the timing. The second grouping down is that clinical grouping. The third factor would be that functional impairment score, and then the fourth factor would be the comorbidity adjustment. So we're going to take a deeper dive into each of those different PDGM components. But that is how the architecture of that HERG is constructed. So, and then these factor into what's called that Home Health Resource Group, or the HERG. And then the HERG is then also translated over onto the billing side, which is called the HIPS code. So as we know, home health, a lot of acronyms, so you got to get used to the acronyms. The HERG, the HIPS code, those are 2 of them that we just mentioned. And again, this is going to tie into what that payment level and how the Medicare knows what to reimburse organizations. So let's look at each of the different components of that HERG. We talked about first here the admission source and the timing. So they combine this into one category. There's really 2 options for admission source, and there's 2 options for timing. So the admission source, and again, we'll talk through the logistics as well for how CMS came to these determinations for each of these different components. For admission source, the analysis that they did is they determined that institutional, you have 2 options here, institutional or community. The determination was that those institutional patients are typically higher cost patients, right? They're coming from a setting typically where they're getting care prior to getting home care services. They're the higher acuity patients in most cases, and a lot of times they're requiring additional care or more care than someone coming from a different setting that is not one of these institutional settings. So you can see the list of institutional settings that we have on that bullet, that sub-bullet there. The patient's either coming from the acute care hospital, from a SNF or a skilled nursing facility, an inpatient rehab facility, or an inpatient psychiatric facility. Those are the 4 care settings that qualify as institutional settings. Now, this care has to take place in the 14 days leading up to that home health admission. So if we had, again, a patient that gets admitted today on September 11th, let's say the patient was in a hospital back on August 1st, that's more than 14 days prior to that home health admission. So that would not count as an institutional admission, an institutional admission source. It would be considered community, right? So anything besides those 4 settings within those 14 days is going to be considered community. So community doesn't necessarily mean they're just coming from the home. It could be any other care setting outside of the ones that are listed on that list for institutional. The other factor there, so we have admission source. Again, we're either community or institutional. The other factor for this component of the HERG is going to be the timing. You're either going to be early, your first 30 days, or you're going to be considered late. So anything beyond that first 30 days is going to be considered a late period. So it's important here to notice kind of the clarification on that bottom bullet there that says a gap of more than 60 days between the end of that one 30-day period and the start of the next starts the next sequence, right? So if you had a situation, for example, where that patient, again, let's say was discharged at a prior home health agency on August 1st, and we happen to pick them up today, that's a gap of less than 60 days. So that would continue on with that period count, and it would be considered a late period. But if you do have a gap of more than 60 days, that resets the clock on what the timing looks like. So again, we have either early or late. So 2 factors which make up, again, that first component. It's either going to be institutional or community, and then early or late. The second source is going to be the clinical grouping. So what Medicare did there is they did a big analysis and looked at all the different patient characteristics, whether it be age, their sex, also their primary diagnosis, and from that they determined that the primary diagnosis is really the factor that has impacted the resource use. And by resource use, I mean the number of visits that are being performed, also the supplies that are included with that patient's care. And they've now narrowed it down to these 12 clinical groupings, these that are based on the primary diagnosis code that factor into the second component of that HERG. So again, you're going to have the 12 diagnosis categories, diagnosis code categories listed above, starting with neuro rehab all the way through to MMTA respiratory. And that is what each patient is going to be classified into one of those 12 clinical groupings based on their primary diagnosis code. It's important to clarify that we're looking at their primary diagnosis code from a billing perspective and from a clinical standpoint. On that OASIS, the form that gets completed at the patient's admission, and on the claim itself, patient can have up to 25 diagnosis codes on their claim. So this is their primary diagnosis code only that's going to determine the clinical grouping, and the primary diagnosis code must match the primary reason why the patient is receiving home health services. So that's important to factor in there, and that's where sequencing becomes very, very important. You want to make sure that, again, that primary diagnosis code is really the main reason why the patient's receiving care. So that's the second component of the HERG, is the clinical grouping. Here's a little description here, and any of these screens here in these charts, you can see some of them are available right on CMS's website, including this one here. This came right from CMS's. This gives you a breakdown here for the clinical groups, and a little descriptor on what constitutes the clinical grouping itself. So MS rehab, neuro rehab, those are typically your higher therapy type clinical groupings. You can see wounds, post-op for wounds is another one, and it gives a description there on what constitutes a wound care patient. You have behavioral health, your complex nursing, and then we also have, I mentioned before on the slide before, MMTA, yet another acronym here. What MMTA stands for is Medication Management, Teaching, and Assessment. So what Medicare ended up doing is they took a look at that MMTA, which was almost a catch-all clinical grouping when they initially developed the PDGM rules. And then they further looked at the data and said, you know what, there's some of these subgroups that make more sense to operate independent of one another. So they came up with these 6 MMTA subgroups. It's really 5 plus another catch-all, right? So you have MMTA surgical aftercare, you have cardiac circulatory, endocrine, GIGU, you have your neoplasms, respiratory, and then that other catch-all being that MMTA other. So those are the 12 clinical groupings. Again, would be these 6 here for MMTA, and then the other 6 here that were listed on that first chart. So again, that's the first 2 components of the HERG. There are 4. So the third one here will be their functional impairment level. So the functional impairment level is going to be taken directly from the OASIS item. So again, the OASIS would be the form that's completed at the time of assessment for a patient, and it asks various questions, whether it be demographic questions. It also asks questions on the patient's abilities. They're specifically for the functional impairment scores, really what we call the ADL questions, or the activities of daily living, essentially looking at the patient's ability to operate independently in their home. How can they, how well do they transfer from chair to another room? How well are they able to bathe independently? How well are they able to ambulate, dress their upper and lower body? Those are the main questions that are going to be factored in here when we're talking about their functional impairment level. So you're classified into one of 3 categories: you're low, medium, or high. Essentially, how it works is that based on your responses to those OASIS questions, you're assigned a point value based on how well you can or can't perform the function. Based on those number of points, that qualifies you to factor into, again, either low, medium, or high. The high being the highest acuity, being, chances are the more services that are going to be required, the higher cost patients, and therefore the higher reimbursement associated with it. So that's how that factors in there. So again, that's HERG component number 3 would be, again, the functional impairment level. The fourth factor in here is going to be the comorbidity adjustment. And comorbidity essentially is referring to the patient's diagnosis codes. We mentioned on the previous slide for clinical grouping that your clinical grouping is based on just your primary diagnosis code. Well, this comorbidity adjustment factors in all the other secondary diagnosis codes, like I mentioned before, up to 25 diagnosis codes that are reported on that claim. So this comorbidity adjustment is in place if the patient has additional comorbid conditions that, again, from the analysis of the data that CMS looks at every year, CMS has determined that these are going to be your higher cost patients. If you have, for example, a wound care patient with congestive heart failure, that could be an association together where Medicare has done analysis and they factored in that these patients are typically higher costs and therefore they qualify for a comorbidity adjustment. So you're either going to have no comorbidity adjustment, you're going to have a low comorbidity adjustment, or you're going to have a high comorbidity adjustment. The high comorbidity adjustment being the higher reimbursing or the higher case mix item. So a low would be a situation where there's a secondary diagnosis code that is associated with a higher resource use. The high comorbidity adjustment is going to be in a situation where there's multiple comorbid scenarios or conditions that are associated with higher resource use. So this is talking about multiple secondary diagnoses on that list of 25. If they have an association together, again, from the data analysis, those are going to be our higher cost patients that are going to require more services and therefore should qualify for higher reimbursement and therefore that high comorbidity adjustment. So there's a lot of diagnosis codes that factor into, overall from diagnosis coding. So every diagnosis code is going to, there's a full listing out on CMS's website for a resource. That will tell you if your primary diagnosis code, for example, what clinical grouping it fits into. And it's important to know that there are some diagnosis codes that don't fit into a clinical grouping. They would not be qualified for home health. So that's important to look at, number one. And from a comorbidity standpoint, those diagnosis codes, as you're determining what qualifies for those comorbidity adjustments, that list is updated on an annual basis. We'll talk about some of the other pieces that update on an annual basis, but that list of diagnosis codes is something that does update every year to show those interactions together. Again, it's based on the data that Medicare is looking at, and we know that data can change every year. So, all right, we know now all of the 4 components of what the HRG is. And I mentioned before the HIPS code. So what does HIPS code stand for? You can see there, Health Insurance Prospective Payment System. Don't really need to know that piece, but just know that those 2 terms, HIPS and HRG, are typically used interchangeably. Technically, what goes on the claim is a HIPS code, right? So if you look here, each of those different components I talked about has their own position within that HIPS code. So the HIPS code is a 5-position code that's going to go on your claim. If you look at that position number 1, it goes back to what we talked about before, the source and timing. So you're going to fit into either community early, institutional early, community late, or institutional late between numbers 1 and 4. The clinical grouping is that 2nd position of the HIPS code, and it fits into, that's a letter translator. So you can see the associated letters with the clinical grouping listed in position 2. And then the 3rd position would be that functional level. Again, the low, medium, high. You're ranked there either an A, B, or C, depending on what your score is for functional level. The 4th position being that comorbidity adjustment. You're either going to be a 1, 2, or 3 based on none, low, or high. And then the 5th position is just a placeholder. So in the old world, in the prior to PDGM world and PPS world, those HIPS codes were five digits, as it was, for 5 characters, I should say. And really, from a programming standpoint, I think is essentially why they just kept the 5 positions, and they just have that every HIPS code is going to end in 1 under PDGM. So each HIPS code, again, if you look here at the bullets, each HIPS code encapsulates those characteristics. It's created based on the data retrieved at the time of the OASIS completion. So the other piece that's important to note here is that Medicare is going to automatically generate their HIPS code for you. You're going to bill with the HIPS code, but Medicare is automatically going to generate it based on the information that they have from the OASIS and then also from the Common Working File to determine community, the source and timing, community earlier or community or institutional, community or institutional rather, and early or late. All right, so that's going to segue us over onto the billing side. So we'll talk about billing itself. Now that we have some knowledge of PDGM in and of itself, this is going to give we're going to switch gears here over to billing. And how does the billing work? What are some of the important components to know from a billing standpoint? So we're going to walk through the life cycle of a claim, starting from that notice of admission to the final claim itself, and then we're going to talk about the payment. We mentioned before case mix methodology, so we're going to take a little bit deeper of a dive into case mix, and then there's some other factors, some adjustments that also take place that may impact your reimbursement. So that we're going to go through those situations, which are going to be number 1, the LUPA, another acronym. We have the partial payment adjustment, and then we're also going to talk about outliers. So starting with the notice of admission. So this is technically not a claim. It's something that's submitted at the time of that patient is admitted. This is basically the notification to Medicare that I am seeing this patient. It's also a notification to other agencies that you're seeing this patient. So this is something that when you bill that NOA, there's something called the Common Working File. That's where all this information will be stored and where it would be visible to say that, hey, patient John Smith is being seen right now by agency ABC. How I know that is from this notice of admission. So it's a one-time notification that establishes that plan of care for that patient. What's important to know there is that we really want to make sure we're careful of what those dates for the period of care, right? So if you have a patient that, let's say you got a referral today, but you don't admit that patient until tomorrow, you really need to make sure that you're sticking to the actual admission date of when that home health period of care started. So in that example I just gave you, 9/12 would be your NOA date. 9/12 would be the date that you're using for those periods of care when you're looking at that 30-day period of care, as I mentioned before. That needs to start with the actual admission date, which would be in the example I just gave, again, 9/12. So again, it informs Medicare that a patient has been admitted to home health. A couple of very important points here. Probably the most important piece is that first bullet on there is that the NOA needs to be submitted within 5 days of the start of care. If you have a situation, and we're going to talk about timely filing, that's going to be, again, your number of days that you have to actually bill that NOA. If you have a situation where you do not bill within 5 days, you could be at risk of a payment penalty. So you could be in a situation where if you don't bill until day 6, you're not going to get paid for those first 5 days. So again, it's important to make sure that NOA is billed timely, and that the patient is again going to remain active until a discharge bill is or a claim with a discharge indicating a discharge is submitted by the agency. I mentioned before, payment penalties are applied for late NOA submissions, and what this is, I mentioned before, it's not technically a claim. How it gets billed is that type of bill is a 32A. It gets submitted to Medicare, and you'll see it in Medicare's online system that establishes that patient. So we got the NOA billed, and now we're providing services. So I mentioned before that home health services under that plan of care are based on 30-day period of care. You're going to have the NOA submitted, and then 29 days later, at day 30, you're going to have your final claim. So the example I gave before, we're going to have that first claim. That final claim is going to be a start date, episode start date of 9/11. We're going to have a period end date of 10/10, and that's going to be what's billed to Medicare. It's important to know here that you want to make sure that all services that are billed are rendered rather during that 30-day period of care are on that claim. So if there's a situation that you don't want to be in a situation where you're billing too quickly, right? It's just, this is something I would say we see agencies potentially have a problem with, is you bill a final claim on day 31, for example, and maybe there's a documentation, and maybe you're using a contractor from a therapy perspective or nursing perspective, and they don't have their documentation in the EMR yet. You could be at risk of billing a claim without all the visits on there that need to be on that claim. So it's important to make sure that you have the proper number of days set up as you're going through from a billing lag time. Is what that's referred to as. How it works, as you can see there, the type of bill that's going to be billed is a 329, and hopefully 14 days later, you're going to get payment. So it is important to mention there are some billing requirements. I mentioned before, we want to make sure all the visits are on there, but we also need to make sure we have all these other pieces in place to be able to bill that final claim. Number one, we need to make sure we have that face-to-face encounter completed. We mentioned that on a previous slide. Number two, that plan of care, also known as the POC, which is also known as the 485, that needs to be signed by the physician, by the referring physician. That physician needs to be signing that plan of care. You need to have that plan of care signed and dated in order to bill that final claim. Now, a lot of times what will happen is you have the initial plan of care submitted, and you have some additional services. Let's say it's a situation where you had nursing on the initial plan of care. You have all the coverage and the signature and the orders for nursing, but you determine that there probably needs to be some physical therapy added to the case. Well, in that situation, what's called an interim or supplemental order will need to be created and sent to the physician as well for signature. So any supplemental order that's going to cover a visit on that claim that wasn't on the original plan of care, that also needs to be signed and received in order to bill that claim. So it's important to know that all of those orders are received before you bill. The other piece is you need to make sure that OASIS is submitted and accepted. So that's, again, the form that gets completed at the admission. We need to make sure that that's submitted because, as I mentioned before, how Medicare is going to generate their HIPS code internally is based on the OASIS that you submit, and matches that information to the patient. And then we also want to make sure all services that have been provided during the 30-day period and all those services are on the claim itself. So this is a nice little chart here just explaining Medicare, how the actual payment works. So we have the 30-day payment. It's grouped into one of 432 HERGs or HIPS codes based on the information that we talked about. And then we have some of these adjustment factors, right? So we'll talk about this in more detail here. Number one is going to be talking about the LUPA, right? So this says, are the number of visits during the 30-day period below the LUPA threshold? We'll just say the answer is no. The 30-day base rate is going to be multiplied by the case mix, which we'll talk about in a subsequent slide here. And then if there is another factor in there, for example, the case mix adjustment is further adjusted for that wage index area. So important to note that not only will the base rate and the case mix determine what the patient's reimbursement is, but also that wage index. So basically the wage index is where the patient lives. And we know that throughout the country, there's going to be higher cost of living areas compared to lower cost of living areas. That there's a factor for that we'll talk about as well that's going to determine what that payment is. So if the answer, from there, we then ask the question, was the patient discharged and readmitted or transferred to another agency? That's one other adjustment factor, which we call that partial payment adjustment. Let's again, for purposes here, go down and say no. Was it a high cost patient, which we call an outlier? And again, let's say the answer is no there, then that's when the final claim payment is issued. So we have these other adjustment factors, which we're going to talk about now, that are going to potentially impact what the reimbursement is. So let's start with the case mix adjustment to start with. So I mentioned before, each HERG or each HIPS code has its own unique case mix value. So again, let's go back a couple slides here. So if you look here, that 1AA11, that is a HIPS code. That's going to have its own case mix value. And every other HIPS code combination you can think of, and remember there's 432 of them, is going to have their own case mix value associated with that unique HIPS code or HERG. So to calculate that final claim payment, we're going to take that case mix value, and let's say, the average is going to be like a 1, right? The average patient will be a 1 case mix value. You might have a 1.1, you might have a 0.9, but let's just say, using the simplicity factor of saying the case mix value is going to be 1. You're going to multiply that number by the national standardized payment period rate. And that is something that changes every single year. I mentioned before the diagnosis codes change from determining the comorbidity adjustments. One of the other pieces that changes every year is that payment rate, which right now we're in a situation where the proposed rule for home health came out in July. That will be finalized at the end of October. So right now that base rate is $2,057.35. So again, we're going to use the example of a case mix value of 1, multiply that by that 2057. So then we additionally have the factor that I mentioned before, accounting for the different wage areas, right? The wage differences between certain areas. So we have that 2057 is then further adjusted to account for that. So there's a labor portion and a non-labor portion. Think of the labor portion as, all right, we're gonna adjust this percentage of our standard rate by where that patient lives, right? So let's use some extremes. We know that, let's say San Francisco or New York City is going to have a higher cost of living than where I'm at in Atlantic City, New Jersey. Very, very different in terms of what the wage index factors are for those specific areas. So basically three quarters of that 2057 is going to be adjusted to factor in for the wage index. So that's 74.9%. And then we have that non-labor portion of 25.1%. So then I would factor in, let's say the cost of living, and I'm going to use a number that's not accurate, but I'm just going to use it for illustration purposes. Let's say New York City has a wage index factor of 1.5, like 50% higher than cost of living anywhere else. I'm going to multiply that 74.9% of 2057 by that 1.5, and then I'm going to add it to the 25% of 2057, the 25% being the non-labor portion. And those two numbers added together determine what your final payment is. So that's how we come up with the case mix adjustment itself. Now let's talk about some of the adjustments. I mentioned before LUPA, yet another acronym. This is a situation, what LUPA stands for is a low utilization payment adjustment. So these are going to be your lower utilizing patients. So let's say you have a patient that you're only seeing once or twice in that 30-day period. Chances are that's going to be what's called a LUPA. Other patients you're going to probably be seeing 10 visits in that 30-day period. So that's going to be the difference between that. So each of those 432 HERGs or HIPS codes that we talked about is going to be assigned a specific value, a specific threshold of visits that are required to be made in order to receive that full payment. If it's less than that, let's use that example before we saw the 1AA11. Let's say that's going to have its own unique LUPA threshold. Let's say the LUPA threshold for that is 2. If that agency performed only one visit over that 30-day period, they're going to get paid on a per visit rate rather than that case mix adjusted 30-day payment rate. So in that example, you would only be getting paid for that one service. Let's say it was a skilled nursing service. So you can see here in this chart on the bottom, these rates are updated every year, just like the base rate is updated. In that example, you would get paid for that one visit, $172.73, rather than the full period payment amount, which is going to be around that $2,000 number that we saw before. So again, if it's below the LUPA threshold per visit rate, if it's at or above, you're going to be getting the full $2,000 adjusted full period rate. So you can see there the LUPA thresholds are going to vary anywhere between 2 and 6 visits. So the lowest of the low is going to be 2, and the highest of the high is going to be 6 for determining that number. And again, the LUPA will be determined based on that unique HERG, how many visits you did in that 30-day period. The next adjustment we talk about is going to be the partial payment adjustment. So this is going to be in situations where one of 3 things occurs. Number one, and it's all going to be within 30 days of that original period start date. So number one, let's say they transfer from one home health agency to another. Let's say you were on service from 9/11 and then you discharged from that agency on 9/15 and another agency picked up the patient on 9/20. That would be an example of a partial payment adjustment where that patient got picked up somewhere else. You might see that a lot with snowbirds, for example, who are traveling from, they live in the summer in the Northeast and in the winter they go down to Florida. That would be an example of a potential partial payment adjustment. You might also have a situation where the patient gets discharged. Let's say, they went home and maybe they had another event and they ended up back in the hospital and they had to come back on service for home health. So that could also happen where the patient discharged and readmitted to the same agency. There's also the third factor is going to be situations where the patient changes their insurance coverage from Medicare traditional to Medicare Advantage. So in those situations, again, same thing, it's going to qualify for a partial payment adjustment. So how the payment itself works is that the payment is prorated based on the actual length of that 30-day period when when that transfer of the discharge of the insurance change occurred. So we'll go back to the example I used before. Patients on service from 9/11 to 9/15, so they're on service for 5 days. Instead of getting paid that full $2,000, let's call it, they're only going to get paid 5/30 or 1/6 of that $2,000 because it's going to be a prorated amount based on the number of days of that period. That's how the partial payment adjustment, I should say, works. The next factor we see there is the outlier. This is going to be a more complicated scenario, but this essentially is going to be for your high cost patients. So if you have a patient that you're providing many more services than what you were expected to pay, you may, in those instances, end up qualifying for an outlier payment. So again, it's a little bit of a complex formula to determine that outlier. Luckily, the EMRs will figure that out for you to be able to do that, and Medicare figures that out for you as well. But essentially how it works is that if your costs are greater than the wage index case mix dollar amount, plus an additional cost on top of that, which is what Medicare refers to as the fixed dollar loss ratio. You might hear the abbreviation FDL. FDL stands for fixed dollar loss. So basically, if your costs are exceeding, let's say that $2,000, $2,000 is your cost. If you have an additional 35% loss on top of that, so an additional, let's call it $700 on top of that, that's when there's going to be a situation where you qualify for an outlier payment. So an outlier is in most cases, you're not going to, there's going to be patients that you're probably, the agency is losing money on. The costs are going to be exceeding what those, what the reimbursement is, but Medicare basically says you should be getting some additional payment in those high cost situations. So if they did have a scenario like I just outlined, where let's say it was a $2,700 cost on top of the $2,000 reimbursement, you get an outlier payment on top of that. So, and what that outlier payment equals to is it's an 80% of whatever that loss amount was. So in that example before with that $700 I gave you, the agency would get an additional 80% of that additional $700 cost as part of that outlier payment. All right, so we covered home health. I will say hospice is a lot more straightforward than home health. Home health has a lot more complexities, a lot more adjustment types. Hospice billing is more straightforward. We're going to go into some detail here on how hospice billing works. Starting with the requirements, we're going to go through the different levels of care and how that whole piece factors into your hospice billing and what that looks like. We're going to talk about the types of bills for hospice claims, the notice of elections. If you remember, we talked about the notice of admissions, NOAs. Basically, the NOE is the hospice version of that. Sequential billing and how that factors in, the notice of termination or revocation, and then how the actual reimbursement works. So again, switching gears here, this slide looks familiar. We had one out there for home health as well. What the requirements are, this is more of a reminder here for coverage for hospice. Number one, the patient must be terminally ill and certified to have 6 months or less to live. Services must be reasonable and necessary for the palliation or management of the terminal illness and its related conditions. The other requirements there is that a patient must sign a notice of election statement, and a certification that the individual is terminally ill, which is completed by the physician, the patient's attending physician, and the medical director. You can see there a plan of care must be established before services provided as well. So levels of care. So how it works for hospice is we have 4 levels of care. Each of those are included on the claims. Really, all of your levels of care are going to be included within your claim when you go to bill. So you can see there the first level of care that we see, and the most common that we see, is called the routine home care, or RHC. You can see how that's laid out there. So this is the most common level of care. This is going to be anytime you're providing hospice in the patient's primary residence. How it works from a reimbursement standpoint is we have 2 tiered rates. If you remember, for home health, we have the early and the late, right, with the periods of care, early being days 1 to 30, late being anything after that. Hospice is similar, where they determine that those initial days of hospice care, similar to the initial days of home health care, tend to be higher resource use, and we tend to see more costs for those agencies, for those patients. So what Medicare has determined is that days 1 to 60 should be at a higher tiered rate from a reimbursement structure compared to days 61 and beyond. So that's how it works from a rate structure. So for routine home care, days 1 to 60, higher rate, 61 and beyond are at a lower rate. You can see there the day count resets if the patient does not receive hospice for 60 days. So if similar to that whole early late that we looked at for home health, if there is that gap of 60 days, that's when it resets for hospice. If not, it's going to continue on with that 61 plus lower rate. You can see there the codes that are required to bill for routine care. And then we'll switch gears over here to the continuous care. So continuous care is basically care provided for a minimum of 8 straight hours and a maximum of 24 hours a day to manage pain and other acute medical symptoms. They must be predominantly nursing care, at least half of those visits. And how that's going to be measured and how it's going to be reimbursed is going to be in those 15-minute increments, compared to, with your routine home care, it's a per diem is what they refer to it as. It's a daily rate, regardless of the number of visits that are being performed or the length of those visits. You're going to get that same rate no matter what. For continuous care, it's going to be, again, based on those 15-minute increments on the actual length of the visits. You have your respite care as well, or IRC, inpatient respite care. So this is, temporary relief for the patient's primary caregiver, provided in a hospital, hospice facility, or an LTC facility that has sufficient nursing personnel. The maximum you can have for respite care on your claim is 5 days. And the other piece, the other level of care that we have here is GIP, or your general inpatient care. So this is, again, from a setting standpoint, this is important to know here, is that these are situations where the patient can't be, the care that's being provided can't be provided feasibly in any other setting besides an acute setting. So this is, care that's being provided in a Medicare certified hospital, hospice inpatient facility or a nursing facility that has 24/7 RN availability. From a reimbursement standpoint, we'll get into that in a couple of minutes. That GIP cost is going to be much higher, and you'll see the reimbursement is follows it as well. So again, this kind of summarizes what those LOCs look like and what the how they're grouped. We have the RHC, the CHC, the IRC, and the GIP. Again, I told you a lot of acronyms we're going to be throwing at you. The other piece that you'll see here is those Q codes. It's important to notice, and we listed those Q codes out there on those previous slides underneath those specific levels of care. But this is telling Medicare where those services are being provided. So you can see the Q codes and the associated facilities or home that correlate to those Q codes, and when it's appropriate to use versus not. As I mentioned before, respite care, GIP, that's going to be in that acute setting. So you can see here for that first one, Q5001, which is the home, you can see the only levels of care that are being able to be provided in the home are the routine home care or your continuous home care. In fact, the only setting you can see there, Q5009, is place not otherwise specified, which you need to specify what that place is on the actual claim itself. But you can see that's the only one that really has that qualifier that you're allowed to have all those levels of care. So even for example, some of the routine care that can be provided at any of those different settings, but you can see there are restrictions for any other setting beside, or any other level of care, I should say, rather than home for continuous inpatient and GIP. So moving over to the types of bills, we're going to talk about the notice of election as well, which is again similar to the notice of admission for home health. You can see the type of bill itself. This gets into more of the complexities with billing, and again, this is all going to be set up in your EMR when you're generating these claims, but this will tell you what the types of bill are. So you have that either the 81A or the 82A, depending if it's a non-hospital based or a hospital based agency. That's going to determine what that notice of election is. We're also going to talk about the notice of termination or revocation, which is going to be the 81B or 82B. But you can see here the initial visit is really in that number order. Why the number order is important is because this is going to factor in when we talk about sequential billing. Sequential billing basically means you need to bill in order for months. So if you have a patient that was admitted in September, we need to bill September before we bill October, before we bill November. So that's basically how it worked from a hospice standpoint. So this example here kind of walks through each of those different bill types and how that actually works. So we have the 81A, for example, is when the NOE is submitted. In this example, we're going to go back to April of 24. The first claim in the series is going to get that 81.2. So we have the first claim in the series goes from 4/11 to 4/30. One other thing to keep in mind here is that hospice billing works in those monthly increments. I mentioned before, home health billing is just 30 days regardless of when the patient started in the month, compared to hospice where it is billed in those month breakpoints. So the first claim in that series there, the 81.2, would be all of our April billing. 81.3 would be all of our May billing. And then in this example here, we're going to say that patient was discharged in June, and we're going to bill that claim 6/1 to 6/13. That's going to be that 81.4. So that discharge claim gets its own unique bill type. Now let's see in the scenario we had the patient where the month of service was the only month that they received services. Their admit through discharge was all in 1 month. In that scenario, that's when we would use that 1 at the end, that 81.1. You can see an example 2 here on the right where the patient discharged on 4/24. We would just bill all that in one claim on that 81.1. So bill type is important to pay attention to here. Home health, we know your final claims are all going to follow that 329 type of bill for the most part. For hospice, it's going to be unique based on the timing and whether the patient's still active. So again, we mentioned here the NOE or the notice of election. The NOE billing establishes the hospice election in Medicare's processing system, very similar to how the NOA establishes the patient from a home health perspective. We're going to either have that 81A or 82A type of bill. And similar to home health, we're also going to have a timely filing limit, right? That's going to be 5 days after the hospice admission we have to bill the NOE. Otherwise, we're going to have those payment penalties similar to what we talked about on the NOA side. This more talks about some of those exceptions and modifiers that you can bill if you do have a late NOE for whatever reason. Here's some of the different circumstances that you can use, whether it be a natural disaster, an unusual event, system issues, a newly certified hospice, or other circumstances. And again, you have to clarify on that 81A what those other circumstances would be. But basically, there's exceptions for late NOEs, and you have to bill it with that modifier and remarks for why the exception should be granted. So again, I mentioned before, sequential billing is very, very important when it comes to hospice billing. You cannot submit if a patient was admitted here. In this example here, we have our patient admitted on 3/5/24. You cannot submit that April 2024 claim until you submit the March 2024 claim. And similar to what we talked about on the home health side, that there's billing requirements, that same thing exists on the hospice side. There's billing requirements that need to be in place in order for you to bill. So we want to make sure here that the March claim is billed, then you can bill the April claim, then you can bill the May claim, then you can bill the June claim, and then you can bill the July claim. Now, the April claim in that example I just gave is not going to process at all until that March claim processes fully and adjudicates. Adjudicates means it got basically to the end. So we need that March claim to pay before it starts off the pay cycle for the April claim. And I mentioned before, pay cycle for Medicare claims for both home health and hospice are typically 14 days. That's the payment floor. That's the minimum processing time for that initial for the payment to be issued. So let's say you're in a scenario where we didn't bill March claims until May 1st, and I'm going to bill March, and then once that claim's on file, I'm going to bill April. Well, that March claim is not going to pay until May 15th, May 14th, May 15th, and then that's going to kick off that next pay cycle time for the April claim. So chances are that April claim is not going to pay until May 30th-ish. So that's essentially how it works. There's no skipping of the month. It's going to reject in Medicare system, and you need to submit after the previous claim has been paid. And again, that last bullet we mentioned before, claims are billed in monthly increments, something that's important to note. All right, we're going to talk about revenue codes. So if we look at the revenue codes require a Q code, which again is going to be where that patient service location is we talked about before. The visit lines require G codes. That's going to specify which of those levels of care are being provided. And then we have the HCPCS codes, another acronym that you'll hear a lot. Is going to be also in the Hospice Medicare billing codes cheat sheet. So how the units work are, we mentioned before, they're going to be in those 15-minute increments. The value code 61 is going to be on the claim as well. That's going to determine what the patient's CBSA is, and that CBSA is basically that wage index. It's similar to how home health works, where the wage index or where that patient lives is going to determine what kind of adjustment there is on that claim. So having that value code 61 or the CBSA code is going to make that determination. If there's any occurrence codes or patient status codes, that's also going to be on those, another code that's going to be on that claim. The status code is important to know. Just if the patient's continuing on service or if the patient has been discharged, that's going to be indicated in that status code. Transfers and revocations. So these are going to be scenarios where patients can transfer to another hospice, or they could transfer, they can end up getting discharged and then back on service for that same organization, same agency, similar to what we saw in home health. So the transfers can work from that standpoint. There could be a continuation of that. What happens in that situation is there's a continuation of that previous benefit period. Those certification dates are set up by the patient's election period. It's important to get the information from that previous agency. One of the other keys from a transfer standpoint is when that transfer happens, the patient needs to revocate or revoke hospice in Medicare's system. In the common working file, which we referred to before, which is where Medicare, if you remember, for home health, determines if that patient is early or if they're late, or where that patient came from, whether it be a community setting or an institutional setting. They also look at that common working file, which is again where the notice of elections, notice of admissions are filed, to know if that patient's still on service. So the notice of termination or revocation is important to make sure that that's filed, because that other agency needs to file that notice of termination or revocation in order for the agency that picks up the patient can bill. So again, in the scenario, let's say patient admitted here on 9/11, they transferred to another agency on 9/20. That other agency needs to bill that notice of termination or revocation so that that subsequent provider can admit the patient. So that's at that point in time is when the other agency can bill. So the notice of termination is required. You can see it on those bottom three bullets: when the patient discharges or revokes. It closes that benefit period prior to final claim billing, and it must be submitted and accepted within 5 calendar days after the effective date of the discharge or revocation. So we talked again about how the reimbursement works. We have the per diem rates. This is made regardless of how many services are provided that day. The daily rate covers the services included in that patient's care plan, and it may vary based on the type of care and location, which we talked about before. We also talked about the levels of care as well. Here are just some good resource guides. You can see each of the intermediaries. They have those rate sheets. So the MAC is the Medicare contractors. You're either going to be with Palmetto, with CGS, or with NGS, depending on what part of the country you're in. That's going to determine what your intermediary is for who's going to be processing those claims for you. So you can see there, those rate sheets are available for each of the different intermediaries that are listed there. This is important to use because this is really going to be how you're going to validate the payments. So you should be using that from a validation standpoint to make sure that the payment received matches what you were expecting to get paid. We also see their FISS, or Fiscal Intermediary Shared System. So this is the system that actually makes Medicare's payments. And again, from a rate standpoint, it's important to use them from a rate checking perspective. Annual updates, similar to home health. We see these updates for hospice rates for each of those different levels of care that are updated annually. And the other piece that gets updated, I didn't mention before, is that those wage index values get updated annually. So if you see cost of living increasing in different parts of the country, that's another number that gets updated, or another rate that gets updated every single year. One slight difference from a fiscal year standpoint. So home health follows the same calendar year as their fiscal year is. So basically, the new rates become effective January 1st of every year. So it goes from January to December. Hospice is a little bit different. So we're coming up actually here on a new fiscal year for hospice. Hospice goes from a October 1st to September 30th fiscal year. So we'll have new rates in place. And I saw a question already in the Q&A about asking about HOPE, which is going to be a whole new requirement starting for hospice on October 1st of this year. That goes into place here in about 3 weeks. So just to walk through a quick example here of how those rates are calculated, you can see we're going to use Michigan, this example here of how the specifics work. And again, based on the wage index for Grand Rapids, Michigan, you can see the CVSA code of 24340. They have a wage index factor of 0.8405, and that's going to be factored into what those rates are for each of the different levels of care. So we have the routine home care, and we saw before that we're going to have a higher rate for days 1 to 60 compared to days 61 and beyond. You can see for Grand Rapids, it's about $200 compared for the first 60 days, compared to about $160 for the day 61 and beyond. We had those continuous home care, which is about a $60 hourly rate. The inpatient respite care at about $470 per day, and the general inpatient care, which is again going to be that daily rate we mentioned before, that's going to be the highest of the rates of about $1,000. A new addition that's pretty recent in the last few years here is what's called the SIA, or the Service Intensity Add-on. So essentially, again, what Medicare determined is that for some patients in the last 7 days of life, they will have, again, higher cost or a higher frequency of visits as they get closer to end of life. So the determination was made that in those scenarios where we do have more social work visits or nursing visits, there's going to be additional reimbursement for those visits, just because that there's typically more intensity with those visits in the patient's last 7 days of life. So this is, again, just for those two types of visit types. They're reimbursed, again, in those 15-minute increments reported on the line items, and the maximum number of reimbursable units per day is 4 hours or 16 units. You can see that are illustrated there. Again, this is going to be adjusted based on the wage index, and this is what we see as one of the bigger reasons for Medicare underpayments is not having the correct SIA payment. So we can see here, just a quick illustration here, what they're looking at here is the continuous care rate divided by 4, giving that 1483 per 15-minute units, and you can see how it correlates over here on the right, on that chart on the bottom right, with that code and with the 4 units for those 2 visits, which would be 8 units in total for an additional payment of $118.70. So that's how the SIA payment works. Again, from a setup standpoint and from a billing standpoint, it's important to make sure that all that information is updated correctly in your system so that you are getting reimbursed appropriately. All right, so we talked about an overview there on home health and hospice billing. Now let's talk about some of the challenges and some of the compliance issues that we typically run into. Starting with, when we're talking about just home health and hospice in general, I would say one of the biggest challenges is timely filing. And again, with the NOE and NOA process, the fact that we only have those 5 days to get those claims billed, those notifications, I should say, billed, it makes it challenging, especially when you're talking about running into the weekends, because that 5 days includes the weekend. So it's not a situation where it's only counting the weekdays. If you have a patient that gets admitted on a Friday, you basically have until the following Wednesday to get, or following Thursday to get that NOE or NOA billed, right? So it's just so you know, the admission date counts as day 0. So that 5 days would take you to that following Thursday, and it's important. Sorry, in that example, you would have until Wednesday to get that NOA or NOA billed, and if you don't, then you're going to have that payment penalty. So that becomes a challenge. From a claim standpoint itself, you have 1 year from date of service. So you do have much more time to get that. But I mentioned before, one of the bigger challenges when it comes to getting those claims on file are just managing the unbilled in general. And the number one reason that we typically see from a unbilled standpoint is unsigned orders. So it's really important that you have a solid process in place to manage that whole order submission and then the orders tracking process to make sure that when you do submit an order to be signed, that there's some kind of a follow-up process in place to track down the physician to get that order signed. You don't want to be in a situation where you're sending out that order and then there's no follow-up for 30 days. There needs to be a systematic protocol in place. Typically what we recommend is, hey, if you haven't heard in 3 to 5 days, you should be refaxing or resubmitting that order, depending on how the physician typically gets it. And then if there still hasn't been a receipt of signed order within an additional 5 days after that, you really should be picking up the phone and making a phone call to the physician office to see, what's the delay in getting those orders signed, because this can really create a cash flow challenge if you aren't getting your claims out the door. And if you aren't getting those orders signed, you can't bill, right? So that's probably the number one area from a billing claims, managing that whole unbilled that we typically see. So that would be the number one area that I would recommend taking a look at for your organization as you're going through that billing process, is making sure that you have a good process in place from a document management standpoint to track those unsigned orders, do that follow-up, and also have a good process in place for claim submission or for order submission and resubmission. To piggyback off of that as well, we mentioned it's not just that plan of care, right? So it's not just the 485 that needs to have the signed orders. It's also those supplemental orders or those interim orders for those additional visits that are being provided, that may not that have orders as well. So making sure that you have a process in place, not just for that initial plan of care, but also for the supplemental orders. Claim rejections is another challenge, right? So we have mentioned before, clean claims, as long as everything's in place, chances are that claim is going to pay in 14 days. However, some claims may go into a rejection status or in a return to provider status, which require additional action from the agency. So some common reasons you might see there is there might be an overlap situation, right? We mentioned before that whole revocation process for hospice. If that revocation hasn't been posted, you need to follow up with that other hospice to determine when they're going to post revocation, because it's going to basically, your claim will be stuck until that revocation is posted. So really working with those rejections or those return to provider claims, fixing those on a regular basis should be something that is part of a regular routine of a Medicare biller. They should be looking at those claim statuses. I'll also say working the receivable is going to be extremely important, so that, let's say you had a claim on that you billed and it's been sitting out there for 30 days. That should never happen if it doesn't change status. What's going to happen is you're going to originally bill that claim. It's going to sit in what's called an S status, meaning suspended, and it should go into either a paid status, P, or rejected, or T for return to provider. And that's when it triggers your biller to be able to go in and correct it. But if you're not looking at every claim, again, my recommendation there would be, if you have a claim that's been out there for 3 weeks and you haven't seen it pop up on a rejection report or RTP report, I would make sure that you're following up on that to see what the holdup is. You don't want it to be sitting in that S status for too long. So claim rejections is, again, another challenge of making sure that your billers are staying on top of those. Sequential billing, we talked about before. We really need that previous month to adjudicate before that current month can process. So staying on top of that whole sequential billing piece becomes imperative, and making sure that from a hospice follow-up standpoint that you are working those claims in order to make sure that they are processing correctly. ADRs. So this is another area that I mentioned before. You might have a R status for rejection. You might have a T status, but you also might have what's called an ADR. So that's going to go into a status called a status you'll recognize as SB 6000 or SB 6001. Essentially, an ADR is Medicare requesting additional documentation. You don't want to have too many ADRs because it can be a long and tedious process. So how the ADR process works is that you have a specific amount of time to reply back to Medicare. And you need to make sure that you're replying back to Medicare with the additional supporting documentation. They're going to have their internal review and determine should payment be issued, or should this go into a denial process. You don't want to have a situation where it goes into denial or a D status. That's going to require appeal, and this appeal process can drag out. And we're going to talk all about appeals in some of our subsequent webinars, which is a lot of the expertise that we're going to be having with our team to describe some of the appeals processes, some of the audits that we're seeing, and how you should be responding to them. So this goes back to the compliance, and I'll piggyback into some of the other conversations we have here regarding compliance, of why it's so important to make sure that you have all of your documentation lined up and that you have good supporting documentation to all the visits you're providing, all the referral information you're getting from those referral sources, so that the documentation you have supports the need for the services that are being provided. So ADRs is again another area of challenge for agencies, and the biggest challenge I would say with ADRs is that it's holding up your claim payment, right? So from a cash flow standpoint, I'm always thinking on the money side. So from a cash flow standpoint, these ADRs, if they're sitting out there in ADR, chances are they're not going to be getting paid for months at a time, and that could significantly delay cash flow, and you don't want to be in a situation like that. You can see there, the last one, these are all other government audits. So that's another area that if you have too many ADRs and they continually deny, you're really at risk of a potential claim audit. So you can see there, whether it be a UPIC, a ZPIC, a TPE audit, or a SMARC audit, these are all different government audit types that they're either putting you on because of poor performance from ADRs, or they're looking at some of your claims data and seeing some risk based on certain metrics that they look at that are identifying that the agency is at risk because those metrics or those numbers are way out of line with what they typically see with other agencies. So claim audits is another challenge. And again, from a resource standpoint, we know that this is going to put a strain on the organization because you're now going to have, in a lot of cases, your quality folks focusing in on those audits, and it also puts your agency at risk from a cash flow standpoint. All right, so that kind of shifts us over into the key issues in billing and compliance, and then we'll get to some Q&A. Where we see some of those key issues, I mentioned before, documentation. Documentation, I'm going to focus in on home health just for this slide here, and I'll switch over to hospice on the next slide. Documentation challenges, number one is just the documentation supporting homebound status. So it's important that we have all the information we need from those referral sources that support the homebound status, in addition to when the nurse or the therapist are going out to admit that patient, they're completing the OASIS, but they should also have a narrative visit to go with it. And that narrative visit really needs to be comprehensive and make sure that it supports why that patient is getting home care services and why that patient should qualify as homebound. Some of the documentation challenges we see is again, missing or incomplete information. So every visit that you have should have an accompanied note from the clinician describing what took place during the visit. If there is missing information there, or if it's incomplete, that's going to be a challenge when it comes to potential audits for any of those government audits that I listed before. So not having that information is something that again can be a challenge. I mentioned before briefly contractors. If chances are you're using full-time staff who are going to have access to your EMR. They're going to be operating on a laptop or on some kind of a device that the agency provided. But if you're using contractors, some folks that aren't necessarily full-time employees of the organization, and they aren't using your device, and let's say that they're still on paper, and they haven't gotten the information to you. That's another area where you want to make sure that you're tracking any kind of missing information and getting it as soon as possible. You don't want to be in a situation where you get an audit and it turns out, oh, guess what? That therapist never turned in their paperwork, but guess what? I had the visit on the claim. That's a big no-no. That's a huge red flag that you don't want to be caught in that situation. Upcoding or overbilling, you don't want to be in a situation as well where you're in a situation where the visits performed are not matching. In that example I just gave, based on the information in the electronic medical record, I'm not seeing that visit. I'm just basing on what's on the claim. So, or if you had a situation where you're not billing the units correctly, let's say it was a 45-minute visit, but you billed it as 6 units, right? That, remember, those units are billed in 15-minute increments. That's 6 units would be an hour-and-a-half visit. If that situation occurs, that's another challenge that you don't want to see happen from an upcoding standpoint. Billing accuracy, again, we talked before about the completed and ordered, the visits matching from what's been billed versus what's in the actual EMR. But I'd also say completed and ordered visits. Again, we talked about the plan of care. We talked about supplemental orders. What's going to be on those orders is going to tell you the number of visits authorized and over a certain amount of time. So a lot of times you might hear, 3-week 3. That means 3 visits were ordered over a 3-week period. So it's important that you're sticking within that 3-week 3 cadence. You don't want to be in a situation where I provided 2 visits 1 week and then 4 visits the next week. That's out of compliance with what's been ordered compared to what's been actually completed. So making sure you have those numbers match is very, very important so that you're staying in accordance with what was ordered by the physician. And then the PDGM component accuracy. So again, we talked about the primary diagnosis code. You don't want to be in a situation where the primary diagnosis code on your OASIS is different than the primary diagnosis code on your claim. And all of a sudden your clinical grouping is not the same on the claim as it was on your generated from your OASIS. Those kind of inaccuracies can again lead to potential billing audits. Same with the functional scoring, where we know that that's all going to be based on the OASIS answers. as well as your comorbidity adjustments. You don't want to be in a situation where the information doesn't match, and now all of a sudden you're what could be viewed as upcoding because you're including higher clinical high diagnosis codes that result in higher reimbursement. Which leads us to this next bullet here of the inaccurate coding. You don't want to be in a situation again where the documentation supporting the primary and secondary diagnosis codes is not accurate, right? So you don't want to be in a situation where, and we've heard horror stories of this, where agencies will choose a higher reimbursing primary diagnosis, even though there might be a secondary diagnosis code that will be more appropriate based on the care the patient's providing, right? The primary diagnosis code should always match the reason for why, the primary reason why that patient is receiving services. So you don't want to be, again, caught in a situation where that is not the case. OASIS accuracy, same thing. You want to make sure that each of those different OASIS answers is supported by the narrative or the notes indicated by that clinician. So we mentioned before in those ADL questions, if you remember back on the functional impairment score, if there's a situation where let's say the answer could be for ambulation could be a 2, which means the patient has trouble walking, but the note indicates that the patient could walk without any kind of assistance at all. Well, that doesn't jive. So you don't want to be in a situation where that again would be, to me, a red flag. You don't want to be in a situation where there's inconsistencies between what the supporting documentation says compared to the actual answers to the OASIS. And then flipping over to the hospice side here, one of the pieces that presents a risk as well is hospice cap. We didn't talk about this on some of the previous slides, but essentially this is a situation where the maximum for aggregate cap is going to be 10% of annual reimbursement for a patient. These are going to be essentially tied to your length of stay. The hospice cap is for specific patients. You have a certain amount of reimbursement that you could have per patient on average. So if you have a patient, for example, that's been on service for 9 months, we know that the average patient should be 6 months or less. There's going to be exceptions where patients do live longer than that, but you don't want to be in a situation where they're over aggregate cap. So essentially Medicare every single year will have a cap amount set, let's call it around 30, it's in the 30s thousands of dollars, where the average patient, that can be their maximum reimbursement. You don't want to be in a situation where they go over that cap amount. There's also a maximum for the number of inpatient dollars that are spent. So the maximum there, you can see there 20% of days at GIPA respite levels. That's again based on the different levels of care. You don't want to exceed that number. There's going to be penalties if in both situations, both from an aggregate cap standpoint and also from an inpatient cap standpoint, where if you exceed that, there's no additional reimbursement. You basically get a payment penalty. Length of stay concerns, again, this is another area where we talk about some of these government audit risks. And if Medicare looks at the data and they see your length of stay is 50% higher than what the average length of stay is nationally, you're going to be at risk of an audit, right? You're going to be at risk of an audit from a length of stay concern standpoint, but also you're probably going to be running into cap issues as well. So this would be, again, the concern there would be, are there situations where a patient may be getting referred to hospice too soon, right? They may not be necessarily hospice appropriate if those length of stays, if your average length of stay is 9 months. Again, the rule for hospice is that 6 months or less to live. When we start to see length of stay numbers that are out of whack, that's when we start to get concerned. One quick tidbit that I'll add to that is there's something referred to as a PEPR report, and that PEPR report, and we'll talk about this in one of the future webinars, is going to be a good indicator to where your risk areas are. And one of those charts on that PEPR report is going to tell you about your length of stay, and it's going to benchmark you against other some of those national stats when it comes to length of stay, so that if there are concerns, that is going to be indicated in that PEPR report. That's really going to be, I would say, your audit litmus test, if you will, would be that report. Documentation challenges, again, we talked about before, just the documentation supporting the hospice eligibility. We want to make sure that is as tight as possible and as comprehensive as possible in supporting that hospice eligibility. The upcoding or overbilling, this is another area more specifically for hospice than for home health that is another area of concern, just based on the different levels of care and making sure that, again, we saw all those Q codes which dictate where those services were provided. You want to make sure that those match up, and that they're accurate compared to where the actual services were provided. You don't want to be in a situation where you have you're billing for a high level of service and was actually performed, or billing in incorrect units based on those 15-minute increments. And then the other piece is the benefit period. So the benefit periods for hospice is that we have those two 90-day benefit periods initially, and then 60-day benefit periods thereafter. We want to make sure that we're getting those in line, and those are comprehensive and updated correctly on your claims face-to-face. We need to make sure that they have a face-to-face for every subsequent certification after that initial admission. All right, so with that, I know we have a few minutes left here. I'm going to jump into the...
I was going to say, Nick, can you see the questions
I can
in the
see
Q&A
the
panel?
questions.
So if you start at the bottom, those are the first people like Susan who patiently waited for hers. There's some quick ones and some long ones, so feel free to address them as you wish, but I'll keep them fresh at the top.
Yeah, so I'll start with Susan's there on the explaining why ROCs are resumptions of care, where the patient is being discharged from a SNF or a rehab, it counts as a community. So it shouldn't in that example, right? So what's going to happen in that situation? I'll kind of walk you through an example. Let's say you have a patient that's admitted on, I'm going to use 9-1 just because it's going to be easier for me to explain it. 9-1, that's going to be, that first 30-day period is going to be go to 9/30. So let's say that patient gets discharged, transfers to a SNF on 9/20, and they get readmitted back on 9/25. That next period that starts on 10/1 is going to be considered a late institutional. So that's going to be the rare situation. The rarest of situations you're going to see, you're not going to see many late institutionals, but that would exactly be a scenario where it would count as a late institutional. So, so to answer your question there, the patient being discharged from a SNF or rehab, in that ROC scenario, that would not be a community admission. That's going to, or it would be when we're talking about for that subsequent claim, that's going to be considered an institutional. 45 is still required for a single visit episode. The answer to that is yes. If a patient is a complex wound care with extensive costs for wound care supplies, do the wound care supplies have to be included on the claim, or would the outlier payment be made based on the Harroger Hips code alone? So it's funny, the supplies themselves are actually built into the rate, and that has no bearing at all on what the outlier payment is. The outlier payment is only based on the visit costs. So it's a great question and a good clarification there. You still want to bill those non-routine supplies on the claim. That's basically how Medicare assesses what the case mix weights are going to be every single year, but they're not factored into what the outlier payment is. Again, the outlier payment is going to be strictly based on the actual visit costs. So you still would want to include those wound care supplies, though, because that's one of the factors that Medicare, when they were coming up with this whole new clinical grouping structure, they looked at those wound care patients specifically, and they said that the visit costs are in line with a couple of the other clinical groupings, but those supply costs are much higher, and that's what ended up factoring into why you see a higher case mix value for those wound care patients compared to others. Are there new billing requirements changes as a result of the Hope collection tool? From a billing standpoint, I'll get back to you, and I think we have some contact information we can get back, Dan, I believe, for some of these questions that I'm not positive on. You know, we know Hope is coming. I know there's a lot of data collection. A lot of the speculation is that anytime Medicare is gathering a lot of new data, that means that there's probably going to be some kind of a payment change down the road. I don't see that happening for at least a couple of years, but chances are we're going to have some kind of a new payment methodology in place for hospice, but as it relates to billing changes, nothing that I'm aware of is changing on October 1st, but I'll get back to you on that one specifically, Lindsay. But obviously the information is required to be submitted now going forward on starting October 1st. If a patient transfers from one hospice to another, that patient doesn't transfer, they have to revoke this. So again, in this scenario, the hospice that the patient is transferring from needs to revoke in order for that patient in order for that agency to bill that second claim. If hospice has a prepayment ADR for June, all payments after June, that patient on hold until the ADR is resolved. So in that scenario, once the claim adjudicates, so once it hits denied status, you can then bill for the others. So as long as it's in SB 6000, which is going to be, again, that suspended status, Medicare is going to view that as it's still sitting in suspension. But once it denies, that's kind of that adjudication standpoint where Medicare then says, all right, that claim has kind of gone to the extent. Now you still have appeal rates beyond that, but you can then bill your July claims, or those July claims should process after it actually hits that denied status. All right, another question here. Currently now getting bills from hospitals for therapy received while the patient was in the ER. Some of these bills are responsible. Nicole, I wouldn't think on this one. This is more asking for situations where therapy is received while the patient's in the ER. I wouldn't think that you would be responsible for those. I would be more wondering who is providing those services, and that to me, that'll be another question that I can follow up with you on. One of the other questions was asking, there's no sequential billing for home health. That is correct. No sequential billing for home health. Dan, I'll let you handle the recorded question here as we got up to the end here. Oh, you actually already responded to that one, so you took care of that one for me.
And just for everybody, we'll have a version of this available on YouTube where you can stream, so you can watch all of it back.
Perfect. And I saw a couple questions too on the Pepper reports. I thought the Pepper reports were still coming out, so I'll follow up on that one too to see when Pepper reports are coming back out again. I think that brings us to time. Great. Well, I appreciate everybody's time on the call today. We had great attendance, and definitely encourage you all to join the rest of the series here with us in CHAP. It's been great to collaborate with CHAP on this, and a lot of good content, a lot of great experts speaking on the next three. So please continue to join us, and thanks all for joining us today. Take care, everybody.